Hello and welcome to the Patient Educators Update, where we talk about patient education in a clinical environment. My name is Chuck Jones. I'm with Synergy Broadcast. And as always, I want to welcome our guest, Fran London. Hi, Fran.
Hi, Chuck.
For those of you who don't know, Fran is the Patient Education Specialist at Phoenix Children's Hospital in Phoenix, Arizona. And she is also the author of the book, No Time to Teach. This is the book that we use for the majority of our show topics. And this book was voted Book of the Year by the American Journal of Nursing back in 2010. Is that right?
Yeah.
Yeah. And it's available wherever books are sold in both ebook and paper form. And Fran, the last couple of episodes, we've not looked at the book. We've gone to questions that we've gotten on the website and in various forms that I have. And we've got a good one this week. A director of nursing wrote, under the form, it said, "What's your biggest concern with patient education?" And she commented, "My nurses don't realize their patients' needs. They give the same speech to patients with the same diagnosis and do not involve the patient in learnings or needs assessment. Any ideas on how I can fix this?" And when I thought about this a little bit, she says they don't realize their patient needs. I'm not sure that realize might be the proper term. I've been on the receiving end of this, and I can tell you from some of my own personal experiences that it's not that the nurse doesn't realize it, but he or she may be desensitized to the issues. Quick story, back when my son was 2 years old, back in the late 70s, he was having chronic ear infections, and after going to the doctor for months and months and months and antibiotics and on and on and on, the pediatrician recommended we go to an ENT to have drainage tubes put in his ears. Well, we were young parents, didn't know much about that, and the ENT that we went to was a nice gentleman, but he was very matter of fact. "Oh yeah, do this, do that. Yeah, it's surgery, it's no big deal, blah blah blah," and then out the door we went. Well, we weren't quite sure what to do. Internet didn't exist back then, but we agreed to do it anyway because we felt like maybe it was the best choice to get him some relief. So on the day of the surgery, we showed up at the hospital as we should, and I was a little shocked to see there were over 40 other children in line for this same procedure. Not with the same doctor, but they were all there for the same thing. And so prior to this, we were really nervous about it. We were really concerned about it because he was going to be put underneath, under anesthesia, and it was going to, put tubes in both of his ears, and we really didn't know what was going to happen long term, what the issues were. But when I saw that 40 plus other kids were having it done the same day, then I realized that maybe this is not that big a deal. Certainly not a big deal to the nurses and doctors that are doing it. But then doesn't that kind of get you desensitized to the way the patients may feel about this? Because if it's the first, it's the thing about minor surgery. To me, minor surgery is surgery done on somebody else. If it's on me, it's major surgery. I don't care what they say.
Absolutely.
So am I off base on that, or do you think that my assessment is accurate?
Yeah, I think healthcare providers have a different point of view because, whatever the surgery is, even if it's open heart surgery, they see so many of them, they know they work, they know people survive them, so they're not so concerned. So they don't perceive your concern as much because it's something that they know is okay.
Yeah, and that's probably what's happening with this director of nursing. She's seeing that. And because she's not directly in the line of fire, she's a few steps removed back, she's seeing a bigger picture. So what do you recommend for her? Is there something that she can change in terms of a policy or training or encourage her nurses to do that would be different, that would help them begin to see what the patient sees?
Well, that's what you want to accomplish. And I think the easiest way to do that is to go back to assessment. Mm-hmm. So if she could just make it a rule that everybody has to have the patient teach back information before and after education is being done, that will get them to the assessment. And with assessment, they will know not just what the learner knows, but also understand how they feel and what their concerns are, and that will encourage both individualization of teaching, and it will encourage a little bit more sensitivity to the needs of the learner.
Yeah, okay, so you're saying don't wait and use teach back after you've done a whole bunch of stuff, but begin to use it early on to just get some feedback from the patient.
It's harder when you talk about the word assessment. People may think, oh, I have to find out what their reading skills are and find out about their culture.
Mm-hmm.
And so it sounds like a bigger issue, when really all you need to do is to ask them to teach back to you, what do you know about this surgery?
Yeah.
We're going to do the ear tubes. What do you know about it? What have you heard about it? Tell me. And then that will get both what they know and what their concerns are and what their fears are, so then you can individualize teaching to what it is they need.
Okay, that makes a lot of sense, because obviously when you can get the patient or a family member to start talking about this stuff, you're going to hear where is their fear, where is their misinformation, where do they not understand something, where are they apprehensive, and where some resistance might be to what's going on.
Exactly. And even though we need to assess for the things like cultural issues and ability to read, those things could come out in that conversation. You don't have to ask specific questions about those if you pay attention and listen.
Yeah, and that's pretty important, the paying attention and listening. So would you think that the rule that she makes is something that she needs to address in an email, an employee meeting, an in-service? What's the best way to get the staff to understand the importance of this basically simple process called assessment and teach back, and begin to integrate it into their daily workflow?
When you're encouraging a change like that, you probably need to use a lot of different ways to reinforce it, to introduce it, to reinforce it, to help people continue to use it. So I know in my hospital it's in the policy that we need to assess learning needs, and that's described as teach back. And then it's also in services, it's in the orientation. We have a continuing education program about it. So it's reinforced throughout the process.
Okay, and it sounds like if you're doing it at orientation, as new nurses come on staff, it's one of the first things that they understand is, here's the policy on how we handle patient education, and here are the processes that you go through. Yeah, and then how is this monitored in your hospital in terms of follow-up to make sure that new nurses, as well as nurses that have been there 10, 15 years, are incorporating that into their process?
Well, we also have annual competency checks. So it's patient education skills are included in the competency checks. And because it's part of documentation, it's easy to check the documentation to see if they are doing that assessment. Because what you need to document is what the family, in my case, because it's a pediatric hospital, what the family understands before you start to teach. So that needs to be documented.
Yeah, okay. Well, that makes a lot of sense. So just to recap, the question that we got this week is, my nurses don't realize their patient needs. They give the same speech to patients with the same diagnosis and do not involve the patient in learning or needs assessment. And your response to that is the use of teach back in the beginning and towards the end, and mix it in with assessment.
Using the teach back as an assessment, yeah.
Yeah, and I like the approach to that, because we sometimes have talked about a patient education process in some of the episodes that we've mentioned, and the great thing about a process is it gives you a roadmap, but it doesn't mean that you have to go through every step. The patient does, but you don't necessarily have to in a particular order. You can start the process, and based on feedback that you get from the patient, you can loop back and redo something or position it in a different way. And so in your mind, you're following the process as it relates to the patient, and you're making sure that you're doing an assessment or discovery of how they feel, what they know, what they need to know, how they learn best. You're providing information that's then individualized, and then you're asking them for teach back and show me so that you can judge how they're doing, which then helps you adjust how you go the rest of the process.
Exactly. That it basically gives you feedback so that you can change how you approach things. So you're using the most effective method and being very efficient about it.
Yeah.
Problem with just giving us the same speech to everybody, you're actually wasting teaching time.
Yeah, and I would also submit that if you do that and you do 20 or 30 of those a day, towards the end of the day, you're not providing the same information because your mind fills in blanks that your mouth doesn't say. And the reason I can say that from personal experiences, I used to do an awful lot of training back in another lifetime, and I would do the same process 10 or more times a day. And when I videotaped myself, I would see dramatic differences between how I did it in the morning, which was much more comprehensive because I was fresh, and how I did it towards the end of the day when I was forgetting stuff, and boy, was I in a hurry.
Exactly. So if you change the teach-back method and ask the patient, what do you know about this, that will help you keep fresh.
Yeah, that makes a lot of sense. The book is called No Time to Teach, and it talks about all different ways where you can incorporate some of the things we talk about in our different episodes to actually save time in teaching and individualize it for the patient to make them feel much better. Fran's book is available wherever books are sold, like Amazon and your local bookstore, and you can also download it as an ebook for the Kindle and whatever. And then for those of you who may want to do some group teaching or in-services, if you'll contact Fran's publisher, Pritchett & Hull, their website is p-h.com. They will make you a very good deal on a bulk purchase. So I would encourage you to do that. Fran, why don't you tell folks where they can reach you online?
Well, I have a website at www.notimetoteach, and I'm on Twitter at notimetoteach.
Okay, and I want to let folks know that last week, of course, by the time they view this, the time won't really matter, but I put a Patient Educators Update page on Google+. And so I'll make you an administrator, and I'll be an administrator. And so we'll post all the videos up there, and then we can post other comments and things like that. I think it'll be a good neutral site for folks to comment on patient education as that social network grows and becomes more popular. And I'll include the link in the show notes. Because the way Google does it, it's lots of numbers and letters, and it's not, real memory friendly. So we'll fix that. And for hospitals that might be interested in using and incorporating video on demand with their patient education, you can reach us through our website, synergybroadcast.com, or you can Google MMDS, or Medical Media Delivery System, which is our video on demand system, and we'll be happy to talk to you about that. So, Fran, thank you so much for your time this week. I look forward to talking to you next time.
Bye, Chuck.
Bye-bye.